of Community Medicine at Dr. D.Y. Patil Medical College, Pune, where he plays a pivotal role in advancing public health education, research, and community based healthcare initiatives. His contributions to the field have helped shape the understanding and implementation of preventive and promotive healthcare practices. We are extremely delighted to have him with us today, and he'll be speaking on the topic Outbreak Investigation Step-by-Step Approach. So, you may proceed with your talk, sir. Over to you.
Thank you, Aisa, and it's always a pleasure to come on this Clirnet platform. So today the topic is quite important with outbreaks occurring all over the globe and the fear of a pandemic. So I'll be giving an overview of step-by-step approach to outbreak. And after that, I will be giving some illustrative examples of lessons learned in the outbreaks I have had occasion to investigate in the armed forces. We have a big challenge of outbreaks because large number of troops stay together, and we get common source outbreaks, we get respiratory outbreaks, and so on. So from there, lessons learned. Of course, those lessons, my first-hand experience were more than 2 decades old, but the principles remain the same because I served in the armed forces more than 20 years back, and during that time, I was heading the mobile epidemic team, which had occasion to investigate this outbreak. So I'll be giving some illustrative lessons from this outbreak. So first, I'll just go through the steps. For that, I will project some slides, and then we can subsequently we can see some practical lessons which I had occasion to investigate some outbreaks. So of course, this is the topic and this is the scope of the session. What is the definition? How do you say it is an outbreak? And what are the activities for investigations? And what are the steps? And of course, as I said, we had occasion to investigate all types of outbreaks, waterborne outbreaks, respiratory outbreaks in close, crowded conditions, different terrains, vector-borne outbreaks, or troops are exposed in the forests. They are exposed in highly malarious areas where, or sometimes typhus outbreaks are there. So I will give one example from each type of outbreak. So this is the definition when there is an unexpected spike in disease occurrence, and then we can suspect an outbreak, and we have to identify the cause, and so that we can interrupt the outbreak, we can interrupt its spread, and prevent future occurrences. And for that, we should have a very good continuous monitoring and surveillance system of common endemic diseases, which are the baseline level. Without that, we can never be sure of an outbreak. It may be just seasonal spikes. So we have to compare with the exact corresponding season of previous years, 3 years, 5 years, 10 years, to know whether this occurrence is beyond expected. And then when you are actually investing it, there are different domains. There is a field work, data tracking, and then clinical. Clinical signs, symptoms of individual cases, syndromes, identification of syndromes. What are the clinical case definition for immediate rapid field work? Then we require lab investigations, and we require field work includes not only maybe house to house survey, maybe identifying new cases, but fieldwork also includes the environmental surveillance. What is the terrain? What are the surroundings? What are the whether there are any forest, whether there are any vectors, what is the water supply? So it has all this has to be triangulated, and most of the time all these while explaining, we are explaining step by step, but most of these activities can go on simultaneously. But when we write down, when we try to analyze, we see whether each step has been covered or not, or there are some missing work, so that we go back. Sometimes we may have to go back to the field to find out something which we had missed earlier. And of course, there will be patients in an outbreak. Suppose there is an outbreak of severe diarrhea, waterborne disease. We have to simultaneously care for the patients. Medical care is important to save lives. So we have to identify, we have to have enough number of, depending on the type of outbreak, we may have to have number of oral rehydration solutions, IV fluids, beds, and other provisions. And we should have an estimate of the number of cases we expect for placing a demand for supplies. Maybe we may require extra health care personnel also. And analysis, we don't have to wait for the final analysis to, we have to start the life-saving measures simultaneously. So these are the steps. The first, before going for an outbreak investigations, like we had to move at short notice, you should have a team, well-coordinated team. There should be a well-designated leader of the team, because in an outbreak, there are a lot of advices, lot of rumors, lot of speculations, sometimes conspiracy theories and all that, you know. So there should be a team leader who can lead the team and coordinate all the field work. There should be proper what type of outbreak it is, how you will travel, what are the provisions. Then we require, sometimes if you are going for a outbreak investigations which is highly contagious, protective equipments, gloves, mask, and other things, and also we have to insure the persons, because suppose a person catches the one of the workers who is going to investigate, he or she gets infected, and there should be insurance cover. And of course, existence of outbreak, it depends on the baseline data. Then confirm the diagnosis. That is the case definition. You have to first have a laboratory confirmation. You may not confirm, a large number of cases may be there. It may be not very resource, proper use of resources to confirm the diagnosis in all the cases. But you can confirm the diagnosis of a few cases, sample of the cases. Suppose it's a, say, pneumococcal outbreak. So if you confirm streptococcal pneumonia, blood culture, proper. So, and if all the epidemiology related in the same time zone, same place, other people are also having the respiratory symptoms. So you can extrapolate ki yes, we have confirmed these so many number of cases are confirmed cases, others may be suspect cases or probable cases, but for management we can take them as depending on the resources. Confirm the diagnosis is very important. Then we have to make a clinical workable field case definition. Like you cannot wait for lab investigation of each and every case. So you make a, depending on the outbreak, say if you have waterborne outbreak, so diarrhea and vomiting with some fever or without fever, we take as a case, probable case, or a respiratory influenza-like illnesses. Or if it is meningitis, severe neck rigidity, headache, we take it as a case definition. Initially, just from clinical history or examination, we may say it is a suspect case. Or if we have some, say, some tests are positive, we may say suspect. We increase the level of certainty, we can call it from suspect, it may go into probable case. And if we have a gold standard diagnosis, confirmed investigation, which is positive, we can say a confirmed case. So we can rate this while tabulating. And so this can be a working case definition, because in the field, when you are doing for house to house survey or trying to search for other cases, some cases they report, those are the severe cases, but you want to see the mild, moderate cases or those who have not reported, you send your field workers. So you have to give a very simple case definition to a field worker depending on the particular outbreak. Suppose there's a malaria outbreak. So just all cases of fever can be taken as suspect cases because that malaria outbreak is going on. So depending, and then some probable case ki there is shivering or something, then it may be probable. And then if there is a blood smear which is confirmed with malaria parasite, then confirmed case. So depending on that, such cases and track, you can maybe initial stage outbreak contact tracing can be important because to curb the spread. But once the community spread has occurred, contact traces may not be very resource proper use of resources. Then descriptive epidemiology is just mapping the cases, place distribution, person who are getting, and the time distribution. So all this can give a clue to the actual cause of the outbreak. Suppose large number of people fall sick at the same time, large number, it is a common source outbreak. So the graph will go suddenly up and suddenly down. So that is indicates we will show this type of graphs from or illustrative examples. Then the place distribution. Suppose in a military establishment or a training center, there are a number of barracks. So all the cases are coming from one barrack only. So that shows that can give a clue for further investigation in that barrack. So that helps it. And person distribution. Who are the persons who are getting? We will show you from whether they are outdoor workers, indoor workers, whether they are children, whether they are different. So you may get some person. This is called descriptive epidemiology. Then from that we form a hypothesis, a tentative hypothesis, and then we test it. Suppose we find this is the water is the cause and this is the barrack. So then we tested, we compared the rates in that barrack and compare it with other barrack, comparative group. So that becomes the testing the hypothesis. Either we take, or there is a food poisoning outbreak, we take people who have eaten particular food and people who have not eaten from the history, backdated. And we follow them that those who have eaten, they get different items. So one particular item, we find a great difference. So that becomes the analytical. And then we implement the control measures. We find this is contaminated, or we find a particular water point is not having free chlorine. That shows the chlorine is used up as a contamination. We repair that. We try to dig. We find to see for any contamination. Mostly the waterborne outbreaks like cholera or even typhoid. We have investigated a common source outbreak of typhoid, largest series ever published. I'll show you the paper. All the people were getting at common source. Suddenly, large number of fever cases, we confirmed it as Salmonella typhi on blood culture. So then we could control measures is to change the water supply to then communicate findings are very important to the administrative authorities, to public health authorities and we are, even for publications, because it is education to help others share your work so that similar accidents are avoided in future. So before anyone going into the field, we should have logistics. As I said, what are the equipments required, whether reagents are required or media is required. I have been moving during this outbreak investigations with the microbiologist who used to carry his own media from FMC, which is of good quality. And I was very skeptical why, but when we went to investigate the typhoid outbreak, enteric fever outbreak in a remote place, in a regimental center, we found the local media, the local culture was coming negative because that media had expired or not of good quality. When the microbiologist who carried the media, he cultured it in the media taken from FMC, which was of assured quality, and he could 60-70% cases he could identify Salmonella typhi. So this logistics is very important, quality of reagents, media, operational transport, other things. So it's a 50% of the work is administrative. Administrative framework and it should be in place. Chain of command, authority to a leader, assembly of expertise. You require an epidemiologist who can do this field investigation and analysis. Then you require a clinician for treating the individual cases and also trying to diagnose clinically first, suspect case, and you require a microbiologist or lab. Sometimes you may require an entomologist for vector-borne diseases to identify the vectors. So depending on that, you require a large number of team and field workers or medico-social workers, house to house, and operational readiness. There is a quick reaction team. All health centers, big centers, administrative, hospital, district level, there is a quick reaction team which we had in FMC. From there, we used to go to different where everything is ready. At short notice, we can move. We have moved on 2 hours notice also. So these are the definition we may know as an increase in number of cases. Then is common for that place. For each place, there is a baseline level and particular time. Say monsoons, every year monsoon there are cases increase of jaundice or year, but gradually it should come down. And what can be an outbreak in one place may be routine in other case, which is of course unsatisfactory. But if there is sudden rise, there may be something extra which has come which requires attention. And it is not the exact number of cases which is important. Like as on today, we do not expect a single case of smallpox, but if there is a one case of smallpox, it's an outbreak because we don't expect. Similarly, if you get a case of polio, which is on the verge of elimination, so we take it as an outbreak and everything starts contact tracing, house to house, and mass. So this number is not important, but the comparative baseline. So these cases are compared with the baseline, as I was saying, and accounting for noise, artifacts or data tracking. Suppose there may be rumors or some sudden increase, new diagnostic test comes, so there are more cases. Aggressive public awareness campaign, so which can give a false year of a yeah, that suddenly everybody, and the same thing happened in the last pandemic, increased number of RT-PCR tests. So those things has to be taken in account because initially nobody was doing the test. Suddenly everybody started doing test, and this is usually happens in an outbreak. Initially cases are missed. After some time the cases are overdiagnosed. So most of the artifacts occur. So it requires a lot of analytical and data cleaning to understand the real trends. And of course, verifying the diagnosis, you require lab support, and clinical work has to be done, imaging, signs, symptoms. So these are depending on the outbreaks and laboratory validation. So good lab backup has to be there. So it's a multidisciplinary effort, and there are guidelines, NICD guidelines on the net. You will find handbooks for outbreak investigations. WHO guidelines are there. These references I am taking from WHO guidelines. A case definition, as I said, you have to make a case definition. Say, suppose there are certain typhoid outbreak we have investigated. All fever cases we presume to be typhoid suspect. In that situation, not for always, but if we find few are confirmed for typhoid, all fever, and then we do the blood culture and other things, stool culture or whatever, depending on the stage, and we confirm it. Then person, place, time. So and then case classification, suspect case, clinical symptoms can be suspect. Just fever is there, we suspect it in a particular. If there are some clinical signs that say typhoid, there is a mild spleen or some rashes, so we can say probable case. And if we confirm it with blood culture, it is a confirmed case. So intensive true scope of the spread. For that, you may have to look for other cases which are not reported. So spread out to house, active surveillance. Passive surveillance are those who are reporting. So they form the starting point of investigation. Then you can visit clinics, or you can get from the local hospitals, local catchment area, you can ask, or private practitioners, unidentified cases, or even house to house. Then you make a line list. Line list is you each like computer data set. Excel may you name of the person, age, sex, and uh, each line for each patient can gives the probable suspect, probable, confirm, then food eaten, non-eaten, depending on the year. So that is called line listing. That will help you in subsequent analysis and make the graphs and other things. And numbers and rates and all. And once you fill the data in the Excel sheet, earlier it used to be hand, but now they have got computer facilities. Now you can enter directly. There are softwares available, mobile data entry softwares available, handheld. You can enter the data. Even the GIS is available. Spatial mapping can be done. So a lot of each row signifies the individual patient, while the columns break down critical identifier, demography, clinical signs, exposure variables, other variables which you want to correlate with the person getting sick. And from the pattern, you can get some idea, descriptive epidemiology. So time, place, and person. Time is the epidemic curve. If you find suddenly time is on the x-axis and number of cases on the y-axis. So if you find suddenly cases up, sudden spike up, that means some common source. If you find number of peaks and curve, that is person to person transmission. One group get infected, then after some time incubation period is there. Other group get, so that is different. If it is a common source waterborne outbreak, there is a sudden rise. Place is a GIS, geographical mapping, and person is age, gender, occupation, vulnerable, certain. We'll give example. This is the epidemic curve. This is from the outbreak of hepatitis E. We had investigated regimented more than 200 cases of hepatitis E had occurred, 250 plus cases. And we found this epidemic curve, sudden rise and sudden fall. And we did the subsequent investigations we found from particular cook house or barrack. And then we found out the water supply was contaminated. The pipes were passing through the soakage pits and sewage lines. So there was a cross contamination. So we could, and we did the IgM studies. We sent about 190 samples we sent to NICD and to FMC, and we found about 80% IgM positive out of the 190 samples. So we confirmed it by the IgG against hepatitis E. So we did against all the, because the jaundice was there. So we did against hepatitis B, A, D, but we found the IgM high levels against hepatitis E, anti-hepatitis E. So it was confirmed that way. So then we have to form the hypothesis that is waterborne. Then we compared it, this barrack compared to other barracks. So that gives the initial, it's something like detective work, where to look for further investigations. Then we found this barrack is the maximum cases we are getting. And those who have visited this cookhouse, this was a huge regimental center, more than 1,000, and people mix and intermix. So we could trace all who has come from the cookhouse or visited their friends. They were getting the hepatitis, the jaundice and fever. And then we compared to the others. So then we asked for the exploration, and another way, we know hepatitis E is waterborne, similarly typhoid. So we do a serial, all the taps, we do the free chlorine. You know, water is chlorinated, and if there is no free chlorine at one particular point, between 2 points, here it is free chlorine, here it is missing, in between these 2 points, because the bacterial contamination or viral contamination or organic pollution will take away the chlorine. So there is no chlorine. So that is one rapid way of identifying where to dig for the cross connection. And once we guided, we could find sewage line and water pipeline miss. So these are the certain things which are in the field. And we can do a relative risk, number of people exposed into this water supply, number exposed, and similarly for food item. Or we can do a case control study. We take the people affected and then similar number of matched, and see back history that person exposed to this food compared to the. So these are the basic epidemiological techniques. Odds ratio. I'm not going in detail, but you can get in some book. I'll giving the references also. And you can simultaneously, like we identified, this is the leak, we immediately replace the faulty pipes. We call the engineers, because that they are also part of the team, public health engineers, source control. And similarly, other also vector-borne disease also, I will tell you what we did. Interrupting transmission. Once we find out the dynamics of transmission, we can interrupt it. And we targeted population can be given some prophylaxis therapy, like say outbreak of typhus, we can give doxycycline or antibiotics or vaccine to susceptible, depending on the disease. And communicate the findings. This is the final stage to the health authorities, to the publication, for the wider scientific community. And now I will give you some illustrative example. So lessons from the field, and each investigation, what the lesson we learned, which was unique. So this is the enteric fever I was seeing. It was somewhere in early 2000, 2002 or 3. Big regiments, there were 95 cases of fever, and there was unfortunately one death also. And when we investigated, we found it was, as I said, the microbiologist had carried his own culture media, whatever media they use, bile salt, I think, bile salt agar or something for enteric or salmonella typhi. So those, you have to have a microbiologist for this. And this is the, when we did a spot map in the same typhoid outbreak, enteric fever, we found that this arrow is there, that particular barrack is having all the cases, all the almost 100 cases, and those who have visited that barrack. And then we found the free chlorine missing between this barrack and the adjoining barrack had free chlorine in the tap water, and this barrack was not having the free chlorine. And there was a pipe. We asked for the digging of this eh, region between the two barracks, and there was a lot of resistance first because on the surface everything looked normal. But we had our serious doubts, and you can see these two circles, dark circles in front, from adjacent to this barrack were the leaks of the water pipeline, and this square ones are the septic tanks or soakage pits, some sewage line. So there was a cross contamination, and once we could remove that, the cases were controlled. And of course, we did all the samples were there. We did a antibiotic sensitivity test, which guided the clinical management. Because as you know, enteric fever can be a challenge nowadays because of drug resistance. So we could save, except for one patient who died. And this background of this outbreak was usually we never, in fact, I served more than 27 years in the armed forces. This was the first outbreak I saw. Prior to that, there was a Kasoli and other places where we were getting the typhoid vaccine. They stopped the manufacturing. So all troops are giving vaccine against typhoid because it's a common waterborne, and troops preserving the health of the troops is important for operational reasons. So the typhoid vaccine was interrupted for preceding 3 or 4 years. So this then we recommended for, and again it was, I think now it is reinstituted back. Besides that, the old pipelines, other things in all places, they get corroded, they get leaks. So this was the enteric fever. Then this is the outbreak of pneumococcal pneumonia among recruits. So this was a lesson which we learned was that this outbreak, again, large number of people, young recruits in a regimental center which was in a hill station in southern India. Hill station in southern India, they were falling sick with cough and lobar pneumonia and other things. And the team was at 2 hours notice. We had to move from Pune to this southern from FMC Pune, and that particular period, that particular time, there was a outbreak of pneumonic plague somewhere in Himachal or something. So that was also hill station. So there was a great apprehension ki whether it is a pneumonic plague or something, and we were very scared, myself and the microbiologist. And while we were flying to the place. I asked him what type of sample. Bola, in this type of cases, we usually like postmortem sample. And he was already worried that there will be some casualties. So we were also worried. But luckily, when we went there, he took some blood samples and blood culture, and he could identify streptococcus pneumoniae. So it was a pneumococcal pneumonia. Another lesson learned during this outbreak investigation, and there were number of cases, about more than 50. The whole ward was full of people with lobar pneumonia, and not only lobar pneumonia, there were number of cases of bronchopneumonia, one odd case of meningococcal also, meningitis. Then we studied and the literature, and the streptococcal pneumonia can give rise to meningitis also sometimes. Of course, they were responded to antibiotics. One death only here also. It was an elderly person. And this place where, in fact, we missed meeting Field Marshal Maniksaw. He was also stationed here, staying there after his retirement, and his helper, his orderly, was also admitted with pneumonia in the ward. And before we reached there, the team had already of a pulmonologist had gone from Bangalore, and he had gone, and since his orderly was admitted, so authorities said you should examine Field Marshal Maniksaw also. Luckily, he was fit and fine somewhere in 2002. And had we gone a day earlier, we would have had the myself and the microbiology. So that is one of those things. Another thing which we learned here is actually, at least I learned, microbiologist, I asked him why you want blood culture for each patient, why you are not taking throat swab, pneumococcal pneumonia. Then he said, Ki these are commensals, streptococcal pneumonia, meningococcal. Just having it in the throat doesn't mean that this is the person is having this, because for that you require a tracheal tap or you require a blood culture. So this was a good lesson that just having the organism, there are so many organisms in the throat, so many organisms in the gut, skin does not confirm the diagnosis. It is the blood culture which is diagnostic. And I was then surprised that during the last pandemic, anybody with a RT-PCR was labeled as a case who was asymptomatic. Then I remembered that this lesson which I learned, probably now the lessons are different. So anyway, this is one of the things which was new for me at least. And this is what I had sold about the hepatitis E. Hepatitis E, that was the epidemic curve, common source, again due to water contamination. Here we had more than, I think, 265 cases. This and the typhoid outbreak, we have published it also. These are the papers. From the papers, I have given the references. Anybody can see in detail these papers. So that will give it's available in the uh, public domain. So this was a hepatitis C outbreak. This was the common source outbreak. And rubella, this is an important trait. This was also a very unusual thing. This is again 2003 or 4. This occurred in a training center, in a officer training center. Officer cadets were there. Large number of cases started occurring of fever with rash. And they were 18, 19, 17 years old, 18, 19, the cadets. Initially, everybody thought dengue or something, but when we went there, I had a suspicion. In fact, one of my postgraduate residents, he was doing MD in FMC, I was a faculty there. He was the first one to say, sir, ये लिटरेचर में बताता है मिलिट्री बैरक्स में जर्मन मीजल्स होता है. I was suspecting measles, but the microbiologist was quite. He took us with like a child saying something. He said, "Yeah, these are childhood diseases. Measles, German measles. ये childhood disease है. ये इतने 18 साल में थोड़ी होता है." Then I said, "Yeah, we had started the MMR and other things. There may be a epidemiological shift." But again, he was very, very reluctant. And that time we didn't have the kit for IgM. So we had to get it from Mumbai. So I said, you do it, at least put for measles and German measles. And my student, that time, postgraduate student, Vikram Grewal, now he is head of the department at FMC, Brigadier Grewal. That time he was a major. That is, I'm talking of more than 20 years back. So he was the one who suggested was German measles, and when the results came, IgM, very high IgM levels among most of the 80% among against German measles, rubella. So this is again more than 160 cases. This is again the largest series ever published, outbreak of rubella. And what is important in this, again a learning lesson, is that you have to identify what is the worst thing which can happen. Rubella is very mild in the young child, in the old child, in everyone, but it is can be very, very hazardous for the pregnant, first trimester of pregnancy. So only thing you have to do in rubella is to just protect the pregnant mother. So there was in this place where this outbreak occurred, this training center was there was a military hospital catering to all the military people and their wives and children and dependents. So first thing we recommended was no families will come to this military hospital. They should be referred to some other, they should not enter the premises, because the hospital was full of these cases of cadets admitted with German measles. They recovered, uneventful recovery. So no cadet, no patient, no family, no civilian family, no dependent, particularly pregnant women. All these gynec cases, antenatal cases were transferred to, they were redirected, transport करके redirected to another hospital 10 kilometers away. So that was the first thing we did. Second thing we did was, because this was a training center, there is a mixing of the cadets with the instructors. So we gave instructions ki any instructor whose wife is pregnant will not come contact with the cadets. They will do office duties. And third thing was, one of my residents who was coming to, his wife was pregnant. I said, you will not come. So these are the things, and then otherwise it's very mild. Actually, that time I suggested also that if we are giving MMR in childhood, we are shifting. This is called epidemiological shift of the age in a childbearing. Suppose these are women, 18, 19, 20 years, women will get rubella. That is a danger. Had she got it in childhood, she would have been. So this is one lesson which was from this outbreak. Otherwise, it's very mild, but you have to see the high risk group. High risk group is the pregnant lady, particularly first trimester. So these are the maculopapular rash from the, and this is the post auricular lymph node rubella. This, so some these are the and this is of course last case is the vector-borne disease. So here we used to get, this is a tribal area. It was a defense station, air force station was there, and every year there was large number of malaria cases. And then we did a person, place, time distribution. We found, of course, there was a malaria season, July, August, September after rains. In fact, it was throughout the year. That was again a hill station, tribal area, heavy forest. So there was a outdoor vector was fluviatilis. And we found most of the people who were getting malaria were the people who are doing the patrolling duty. Families, and here we could give mosquito nets, we do spray, we could enforce strict mosquito control. But the barracks, those who were staying and doing the night duties around the garrison, almost entering the forest, then we could not do. We did everything. We sprayed the barracks. We did deltamethrin insecticide treated bed nets. We gave them odomos to the face to put every 3 hours. But still, the cases were not coming down. Then we went for just a visit to the barracks. As I said, you just go to the field, visit them. Sometimes the data on the laptop does not give the answer. So outbreak investigation is just like detective work. So when we went there, we went to the barracks. We found the toilets were not working. Because water was not there, they were blocked, and most of them, I'm talking about 20 years back, most of them, the troops were from village background. So I asked, what is the problem? Why? Well, no problem. We go in the open, in the forest, and they go near the streams where the mosquitoes were breeding. So then it struck us. They are going in the morning and then the dusk, which is coinciding with the biting time of the mosquitoes. Early morning they bite and late evening they bite. And that is the time they used to go in the forest for the open air, and they were exposing their bottoms. So then we suggested for a short term, immediate way, you take two odomos, put one in the face, one in the bottom, and then the malaria cases came down. So had we not visited, we would not come, we would have, and in the interim, we got the water supply, the toilets functional. So this is something which, as I said, ki nowadays, which was known as shoe leather epidemiology, we used to go visit, talk. Nowadays, we are converting to laptop epidemiologists, making models and projections, and sometimes we will miss simple things, something like detective work. So that's all I think. And these are the references. So these are, of course, first modern infectious disease epidemiology and CDC. These you will get in the website, CDC guidelines, WHO guidelines, and these are the papers. First paper, number 4, is the enteric fever. And then there is a paper on pneumococcal outbreak, a paper on hepatitis C, then the paper on rubella. So rubella and pneumonia, respiratory infections outbreaks too, waterborne outbreaks, hepatitis E and typhoid, and of course vector-borne malaria. So most of these are we are struggling with in our country with respiratory outbreaks. We are struggling with vector-borne outbreaks, and we are struggling with waterborne outbreaks. So we have given some illustrative examples. I think that's all from my side. And if you have got any questions, I can take a few questions. Yeah, so I can take a few questions if there are any.
Am I audible, sir?
Yeah.
Just a moment, sir. So, thank you very much, sir, for this comprehensive and enlightening talk. The presentation was very informative as well as lucid and it was delivered in a very clear manner, sir. Thank you very much. Yes, sir, and we have received few questions from our participating doctors. So, I'm sharing my slides with the questions. You may answer them, sir. Yes, sir, please answer these questions.
So I will same present with acute gastro. What are the common pitfalls that delay outbreak recognition and containment? Okay. Common pitfalls are, I have seen many places, particularly there is still sort of a stigma of outbreaks. So first of the common pitfall is sometimes there is underreporting. Sometimes the administrative authorities, they feel that if they report outbreaks, it will go against them. So these are the common pitfalls and awareness among the people. Then the trust of the people, public health, trust in public health. And then others are, of course, lack of resources, lack of diagnostic facilities, particularly our health services are not equitably distributed to the rural areas, and the conditions of living, conditions of sanitation may be poor, and they are likely to have more outbreaks. So these are the common reporting and lack of health infrastructure, particularly health workers, trained health workers, and training of health workers in early identification of outbreaks and reporting. Acute over 48. How would you initiate? Of course, this first acute gastroenteritis can be either foodborne or it can be due to waterborne or milk-borne, waterborne. So outbreak investigations, you have to again find out person, place, descriptive epidemiology, person, place, and time. So if there is, as you said, 48 hours period, that means most likely a common source, either common food or some water contamination. Then place distribution. You see whether where they have all eaten the common meal. If they are eating a common meal in a common restaurant or common hostel or common cookhouse, that means there is a food contamination. Then time, as I said, you have already given within 48. And the persons who are getting the gastroenteritis and who are not getting the gastroenteritis. First, you identify all those who are having the symptoms. Immediately, you form a case definition. Anybody with a bout of vomiting or loose motion, you label as a suspect case. Then you can send some for lab investigation, stool sample, food samples. And if you confirm and outbreak, the biggest diarrheal disease which has a outbreak potential or pandemic potential are cholera and Shigella. So the lab should rapidly exclude Shigella and cholera. Most others can be self-limiting. Then you have to see for other sign symptoms, whether there is any fever. If there is any fever, most likely can be Salmonella food poisoning. Salmonella is a bacterial food poisoning. So you have to know something about the microbiology, something about the natural. So if there is a fever, you have to suspect Salmonella. Look for any rodents, look for contamination with rodents. That is, it's a zoonotic. And then and this is how you go about if a person plays clinical and also start the management of the cases. If it is gastroenteritis, you will require oral rehydration as well as IV fluids if there are severe cases. So this is how, and you do all food samples, stool samples, vomitus samples for lab, epidemiological person, place, and time distribution, and then you compare those who are affected with those not affected, analytical approach, testing the hypothesis. This is how you go about. This is public anxiety. Immediately, you should have a good communication system. You should reassure them that it is Idea is not to create panic. And unfortunately, nowadays the media takes up, try to whip up panic. So it should be all health services are there. Put the health services in place, send a team as soon as possible. And if they reach there, the public anxiety, and there should be someone to communicate with them in a very transparent manner, reassuring them that if they seek early treatment, they need not be in danger. And that's all. The only is communication, information, and transparency, correct information.
Thank you so much, sir, for answering all these inquiries of the participating doctors so well and in so much detail, and also for generously contributing your valuable time and for sharing such valuable insights with us on our platform. So, we'll be glad to conduct more such sessions with you in the near future as well, sir.
Thank you. Thank you. I'm switching off. Thank you so much.
Thank you, sir. Have a good day.
Thank you.